So, adrenal and thyroid, I think, are two of the very biggest issues that we see, and it gets my biggest audience. So, let's jump right into this. Um, in the first place, you guys know that I am not affiliated with any university, any pharmaceutical company, any supplement company, and because this is not a CME uh, meeting, I will certainly tell you the brands I use. And as I've said before, I'm an agnostic about all this level of evidence stuff. I think the Huff's book, How to Lie with Statistics, is a wonderful start. It was written back in the 50s, and lying with statistics has gotten so much more sophisticated. I really recommend Graeber and Wilbur's Family Practice Examination and Board Review. They've got a nice section about medical stats. And sometimes they just bullshit you. I mean, this wonderful 48% of Kentucky nursing homes are below average. I got that right off the TV. That was a group of lawyers chumming for cases from nursing homes. Of course, the real number is 49% are below average, right? So, it just depends on how brassy these people get. I don't think that all meta-analyses are fantastic. And really expertly performed work can get swamped by a bunch of crappy studies. I mean, not everybody spots the Picasso here among all this. And if they do see it, they'll just call the Picasso an outlier. Are you guys seeing my little bar here in the slide? Ah, there it goes. Thank you. It's risen out of the way. Good. And as you know, I'm not an endocrinologist. I'm a surgeon. I'm a dumbass. But I like this image of a pipe. I hope I am the image of an endocrinologist and can give you some information about it. The first patient I'll talk about, I've mentioned before, she came to see me at age 39. She had been a very stressed child. She developed PCOS in her teens, hypothyroidism from Hashimoto's at age 30. And when they gave her levothyroxine, it didn't do her a damn bit of good, and it hadn't helped her mother either. It turns out mom had done well with Armour Thyroid, so she went on it, and it helped. At age 32, she was having so much GYN problems, she was told she would never have a child, and she became prematurely amenorrheic at age 35, premature menopause. A couple of times at age 37, skeptics had tested blood levels. She had too little estradiol to measure. Her testosterone was low, and her LH and FSH were inappropriately normal, as you can see from those values. So somebody boldly tried to give her testosterone, and my God, it put her in the hospital with severe complex migraine. And then another skeptic the next year decided to really make sure she needed the thyroid treatment. So the doc stopped all thyroid replacement for a month to confirm the diagnosis. And what they found was that TSH was only mildly elevated, but my God, these are the lowest free T4 and free T3 I believe I've ever seen. So, I mean, would you feel comfortable using thyroid stimulating hormone to monitor this patient's treatment levels? I certainly wouldn't. So 2 times here we have with the LHFSH and the TSH, strong evidence of hypothalamic dysfunction for this patient because of the stress, we can assume. When I first saw her, she was taking levothyroxine once a day in the morning, which you guys know depresses TSH. It gives a high blast of T4 to the liver all at once, and it generates a lot of reverse T3. She took her liothyronine unbalanced, 10 in the morning and 5 in the evening. And despite that apparently satisfactory treatment, she had lots of symptoms of low thyroid, as well as her symptoms of adrenal and ovarian insufficiency and low blood sugar. Her doc did random therapeutic levels of free T4 1.21, free T3, oh, that's normal. And her TSH was immeasurably low. As I said, hypothalamic dysfunction. So having worked her up, I suggested that she start the cytozyme AD, neonatal bovine adrenal cortex, hormone-free, a so-called glandular, offering only the nutrition that her body needs for her synthetic enzymes to convert cholesterol to steroids, And I told her to evenly divide her daily thyroid dose. When she came in, she was taking 75 of T4 and 15 of T3 daily. Now, it turns out that giving her desiccated thyroid extract or Armour thyroid, 60 milligrams Q12 would give her 76 of T4 and 18 of T3 daily. It's the same thing. And it consolidated 2 prescriptions into just 1 copay. And she improved her diet for her insulin resistance. And you guys have seen me describe that diet as having low glycemic index, slowly accessible glucose, and a low insulinemic index. And 4 weeks after she did these things, she had her first menstrual period in 5 years, and thereafter cycled regularly every month. She got married at 40 and became pregnant on her honeymoon. And this young man arrived on Valentine's Day when she was 41. So there he is on his birthday, and here he is on his 3rd birthday with his pet dinosaur. And I tell you, every time I see this little guy's face, I feel really good about what I do as a doctor. It's feels good, guys. So this lecture is talking about the adrenals and reverse T3. And as you know, our patients often have problems with both. And they present in ways that we see all the time in our clinic: chronic fatigue, depression, anxiety, insulin resistance, infertility, allergy, chemical sensitivities, and fibromyalgia. These diagnoses are all linked with each other by chronic stress. And stress is defined by physiologists as a challenge to the body's homeostasis. When stress arises, whether it's external or internal, or simply a learned reaction response, the body reacts predictably and in proportion to the magnitude of the insult. When I say internal stress, have you guys ever awakened from a nightmare shaky or with your heart racing or in a sweat? Perfect example of internal stress, I think. Bruce, you're the psychiatrist. Now, the acute stress response, of course, is adaptive when it's triggered by injury or illness. It makes sure that we have adequate energy precursors to stay alive, and it stops any unnecessary expenditure of energy, and it heightens the immune system's protection. And the changes will continue for a week, after which they begin to alter, tending towards resolution unless the stress is prolonged. When it's perpetuated, it may be beneficial, for instance, during starvation, like our ancestors in the winter during the ice ages, or for people living in Calcutta right now who have been studied. But if our stress response is dysregulated, either in magnitude or duration, then here's a nice quote: homeostasis is turned to kakostasis. In Greek, kako means bad. And, I don't know if it's the same reason little children talk about feces as caca. But this kakostasis has bad effects on many of our physiological functions, including growth, development, metabolism, circulation, reproduction, the immune response, cognition, and behavior. The maladaptive chronic stress is certainly well documented on ICU patients. The euthyroid 6 syndrome, the ICU wasting syndrome. And similar problems are identified in chronically stressed people who are not critically ill, only ambulatory. And I think that's a really important contribution. Those are our patients. These people can become trapped in their dysfunction. And as our folks from Nova University in Florida write, the stressed patient's system may be incapable of returning to its normal operating regime. And instead, this crappy new alternate resting state becomes normal for them. They're stuck. Reminds me of a car that's driven off the road into a ditch. You can't drive out of the ditch. You're just there unless you get a tow truck or a team of horses. So these are the people who come to see us in our office asking for help. And chronic stress also links the adrenal and the thyroid problems we so commonly find in these chronically fatigued ill patients. So our role with them is to identify and correct these bad stress responses that alter the adrenal and thyroid function and metabolism. And as you guys know, my philosophy is examine the patient, test for what you suspect, then fix what you find. And then after that's done, evaluate the remaining symptoms and repeat. And you'd repeat that as often until the patient is satisfied or you've depleted all your ideas. We need to address physical issues like diet, nutrition, lifestyle, and hormone balance. And also, by golly, encourage psychological rehabilitation because the patient's choice of coping strategies greatly influences their outcome. Some people choose really good coping and others catastrophizing. So let's start with the adrenal. Here are a couple of references describing the acute stress response. They're free download, I believe. This response is triggered by the limbic system, which is taking inputs from all over the brain and nervous system. Its hypothalamic response affects the adrenals. It increases the corticotropin releasing hormone, increasing pituitary ACTH and greatly increasing adrenal cortisol synthesis and release. And it blocks the production of gonadotropins. It alters the amplitude and frequency of the ohm vibrations there so that sex hormone production is reduced. And that means that the precursors for the sex hormones are now available so the body can make more cortisol with them, which is necessary for saving your life. When the stress response is prolonged, one of two things can happen. Either the HPA axis will continue to be increased, in which case the glands can become hypertrophic. Anselmi described this in dogs in 1936. It's not new. Or, this is the big one, the hypothalamus may become depressed. And the depressed hypothalamus gives you reduced ACTH, just like our patient had reduced TSH, LH, and FSH, right? The hypothalamus just says, oh, screw it. This is too hard. And the cortisol is decreased. Either way, up or down regulated, the altered HPA axis activity, quote, characterizes human stress-related disorders, including chronic fatigue syndrome, fibromyalgia syndrome, chronic pelvic pain, and post-traumatic stress disorder. So we're really onto something big with this. The upregulated HPA axis maintains high cortisol production, continues to suppress thyroid-stimulating hormone, growth hormone, and the gonadotropins. Speaking of the patient we were just discussing, Dana, persistently high cortisol then will lead to cortisol resistance. If you remember that picture of the gorilla blocking his ears, you get fewer glucocorticoid receptors and they have less affinity to their ligand. So you have reduced binding affinity of the cortisol receptor. And it also, the elevated cortisol will worsen insulin resistance, impair thyroid hormone activation. So you get more reverse T3. And it directs the immune system to autoimmunity and atopic diseases, which is why I guess my allergy practice drew a lot of these patients to me way back in the 1980s. So what contributes to the chronically upregulated HPA axis in adult life? Well, prenatal stress predisposes to these problems as an adult, as does early postnatal hypoglycemia, pediatric ADHD and anxiety, major depressive disorders, anorexia nervosa, abdominal obesity, obesity from any stress event, men with Gulf War illness, and mild to moderate Alzheimer's. Now, the other way that chronic stress affects the HPA axis is to downregulate it. And this is about 10% of cases. The downregulated axis can present with symptoms of adrenal insufficiency. All those patients, what my friend Bob describes as sickly high maintenance patients, they have a triad of enhanced sensitivity to stress, increased pain, and chronic fatigue, as well as, of course, they're skinny, they've got hypotension, they've got orthostatic hypotension, they crave salt, dot, dot, dot. And meta-analyses have been performed supporting, I always like them when they agree with what my prejudice is, but these studies have supported connections between low cortisol and the chronic fatigue syndrome, the risk for which is increased 6 to 8 times by childhood trauma, such as the patient one I presented suffered, according to the severity of the childhood trauma. But there's, as we saw in the neurosteroids lecture, the patient's perception of severity can actually be more important to determining outcome than the objective measures of how severe the problem was. So anyway, this link is further supported by other studies of chronic fatigue showing a flattened diurnal cortisol variation. You guys have seen those salivary cortisol that just stays in the kind of low end. It doesn't have the normal high in the morning and low in the bedtime. And often you'll have reduced HPA axis responsiveness because the gland with the low ACTH, the gland just becomes a little atrophic, by golly. What sets people up in their adult life for this decreased HPA function and lower cortisol? It's pediatric recurrent late postnatal hypoglycemia. So hypoglycemia is really hard on the babies early or late postnatal. ADHD again, this time with oppositional defiant or other comorbid disruptive behavior. These kids are really troubled, as I guess, Jocelyn, you know. Obstructive sleep apnea syndrome. My God, how common is that? Especially these days with the massive obesity issues we have. Women with chronic fatigue syndrome tend to have this problem a lot, as do post-traumatic stress patients. And simply getting older. Oh, damn, that's me. So whether or not the patient for years has had chronically upregulated stress response, or they've dropped into the downregulated HPA suppression, either way, they may end up with insufficient cortisol. Even those people with chronically high production will ultimately be exhausted, be depleted. It's like a boxer in the 11th round. He's got nothing left to give. He still looks fine. He's still a lot stronger than I am. But after 11 rounds, with Mike Tyson, man, you don't have a lot left to give. So psychologically, what these guys say is in low cortisol, the sympathetic nervous system cannot be restrained. Cortisol is needed to downregulate the locus coeruleus production of norepinephrine. And so these patients with fatigued cortisol production will have persistently increased arousal, or hypervigilance is the term that Krusas has been using for decades, and we might call it anxiety. So how do we diagnose this? And I mean, the concepts I've just been bouncing off, old to research, but new to us practitioners, and our patients may not have been correctly diagnosed for years. So you start with a personal and a family history, which along with a physical exam will indicate what laboratory tests are going to be appropriate. Symptoms related to chronic stress include anorexia, anxiety, insomnia, overcaution, low libido, and of course the hypothalamic hypogonadism. And you even see symptoms of Addison's, orthostatic hypotension, craving salt, labile, or low blood pressure. Trauma and post-traumatic stress disorder associated health problems include, here's our patient list. We see this all the time: asthma, lung disease, eczema, arthritis, back pain, diabetes, anemia, and ulcers. And this stuff is all related to the consequences of the upregulated immune system and norepinephrine. So hypersensitivity and reduced blood flow to the gastric mucosa. And I've shown you guys the questionnaire I use is 0 to 4, just circle whatever applies to you. And I take 2, 3, and 4 seriously. 0 and 1, I don't worry much about because everybody has something every now and then. I always ask about intrauterine life and birth trauma, childhood illness, stressors, and abuse, and bereavement, of course. Ask about the childhood personality traits of being people pleasers, perfectionists, or the class clown trying to make everybody laugh and like them. They all if correlated with stress and proper psychiatric work. What drugs are they taking? Because there are a lot of drugs that can goof up the HP axis, especially the opiates. And those drugs can also block the metabolism of hormones, including cortisol activation and thyroid hormone activation. And anytime I run into a drug I'm not familiar with, I just Google it. Does this drug affect that gland? And it's amazing how Dr. Google will give you some pretty good answers from the literature. On physical exam, when your patient's obese and hypertensive, you can anticipate they have a chronically increased serum cortisol and insulin resistance. On the other hand, those sickly high maintenance ladies who are slender and frail, that really suggests to me adrenal insufficiency or old Graves' disease. These people are often anxious and tend to be catastrophizers, I think, from the norepinephrine overload. The low blood pressure, the postural hypotension, and tachycardia certainly raise the question of adrenal insufficiency. And frankly, before you diagnose neurally mediated hypotension, before you tell the patient she has postural orthostatic tachycardia syndrome, make damn sure they don't have adrenal insufficiency, please, before you call it dysautonomia. So how do you make sure? Well, let's look at laboratory tests. Now, I'm just going to say elevated cortisol because every now and then we see it. You can do a 24-hour urinary free cortisol. You can do the adrenal steroid profile at Meridian or a Dutch test, or you can send it to Great Smokies, Genova. But a late night salivary cortisol often is awesome. And if your late night salivary cortisol value of 5.24 or higher is seen, that's significantly high, and you need to follow up on that. That's what the university guys at our division of endocrinology say. So I do want you to remember, though, that the increased HPA axis activity of chronic stress is not true Cushing's syndrome or disease, okay? And when people have elevated cortisol because of insulin resistance and hyperinsulinemia, that's not Cushing's either. There are a number of articles about that now in the English language. True Cushing's is verified by the dexamethasone suppression test, so we're all going back to medical school on that one. But what about low cortisol? That's a little tougher. We've seen the HPA suppression can cause secondary adrenal insufficiency. So, people taking suppressive doses of corticosteroids for an autoimmune disease need to wear their alert bracelet or necklace. And as I've said, when the NIH director comes and talks about adrenal fatigue, she always makes quotes with her finger. It's not an accepted medical diagnosis. Thank you, Mayo Clinic, for telling me I'm a chump. But Hans Selye's exhaustion state is adrenal insufficiency due to depleted capacity, and it appears valid, as I showed you back on slide 20. So let's just start out by reviewing what's not controversial, and then I'll get into deeper water here. The differential diagnosis of primary adrenal insufficiency is, of course, Addison's disease. Only 4.5 new cases per million Americans these days. More women than men, mostly 30 to 50, mostly autoimmune in this country. But you also can have the occasional adult with congenital adrenal hyperplasia come through. I've seen one that was unsuspected by anybody. She came to me for amenorrhea. You can see a variety of other things, X-linked adrenoleukodystrophy, a hemorrhagic infarction, infectious adrenalitis, HIV, mostly drug-induced, things that will inhibit cortisol synthesis, like, opiates, cancer metastases. My mother's sister had that, lymphoma, colon cancer, many more. And the natural history of primary adrenal insufficiency is summarized here in this 2001 review from JCEM. Up here, your disease starts, and as the adrenal is destroyed, the first thing that shows up is maybe your aldosterone's a little suboptimal, and you add more and more salt, maybe start getting a little orthostatic. And if tested, your plasma renin is a little bit high to compensate. And then when cortisol becomes suboptimal, the ACTH continues high into the afternoon. And then when the death of your adrenal progresses enough, you simply don't have quite enough aldosterone. I just want you to see here that your body will continue to make cortisol as long as possible because that's the one without which you die. And decreased cortisol becomes clinically apparent only when 90% of the adrenal mass has been destroyed. And the artist jacked this up, so I had to help him out a little bit. I got out my geometry and I measured it. And this is 10% of the area of this triangle. That's when low cortisol becomes clinically apparent and testable. Testable. It's detestable. Lab diagnosis is based on low cortisol secretion, and the clinical guidelines are here in a nice free download. But routine blood tests, as the endotext tell us, can give clues. And the number one clue that I happen to see is hyponatremia. You see that in upwards of 90% of people with Addison's disease. They will have inappropriately low sodium. Watch for it, especially in older people. Those tend to be the people I see it in most often. Also, high potassium, low bicarb. I always keep an eye on the CO2 on my metabolic panel. Elevated BUN, elevated SED rate from the autoimmunity, mild anemia with eosinophilia, and mildly elevated TSH. I've not ever seen that, but I see very few people with Addison's. So what kind of blood tests? So random cortisol isn't really helpful unless it's just crap. If you don't have enough to measure, it only suggests adrenal insufficiency. Try cortisol at 9 in the morning if you have less than 3.6 micrograms per deciliter. It suggests it might be a problem. But I love this. These authors say, look, a normal level within the lab's reference interval, it may be insufficient when the patient's severely stressed, like if they're hit by a car or septic or something. So this is an important concept. What you see right now may not be enough if they need more. You may see what you may be seeing right now is possibly all that they can possibly make to keep going. We'll touch that later. If you do an ACTH at 9 in the morning, the value that's greater than 60 is said to prove primary adrenal insufficiency. And if it's less than 10, there's a confirmed secondary or even a tertiary adrenal insufficiency. These same authors don't like an ACTH higher than 25, but they say keep an eye on it. It may not be enough. Even 10 to 20 may be equivocal. And so they say, well, just consider a synthetic ACTH long test. Sorry, my normal turner isn't working. So how about an 8 a.m. blood cortisol and ACTH and renin and aldosterone in primary adrenal insufficiency? Cortisol is low, ACTH is elevated, renin is increased, and aldosterone is low with high potassium and low sodium. Okay. In secondary or tertiary, which means the adrenal gland is fine. It's just the powers that be, the pituitary, the hypothalamus that regulate it are jacked up. The adrenal may be becoming atrophic. So your cortisol is low because nobody's asking the adrenal gland to make cortisol. And ACTH concentrations are low or low normal because the pituitary or hypothalamus are not working properly. And the aldosterone production is regulated not from the pituitary, but from the posterior pituitary, from the renin-angiotensin system. And aldosterone will continue to be normal if the adrenal gland is alive. So nice little difference to remember. Urinary free cortisol is just not encouraged. I stopped doing it because 0 is normal. 30 years ago, it used to be kind of helpful, but absolutely not anymore. How about saliva cortisol? I used to kind of poo-poo these tests, but I'm finding them increasingly useful. They're easily collected, they're painless, they're done at Quest and LabCorp, they're covered by insurance. And a lot of work has been done with these. A morning salivary cortisol, uh, adrenal insufficiency is considered to be excluded when the morning salivary cortisol is at least 5.8 nanograms per mil, or 16 nanomoles per liter. And less than that is possible, and especially if you get down to 1.8. And then here's another study said that a morning salivary cortisol below 2.65 nanograms per mil distinguished adrenal insufficiency people from normal controls with a 97% sensitivity and a 93% specificity. So as I was reviewing my slides this evening, I went, holy crap, what does that convert to? Because Quest and LabCorp give their values in nanomoles per deciliter, like they're reporting to Canadians or French people. So I did the units lab conversion, and what I found is that 7.31 is totally normal on Quest and LabCorp reports. It's low only on the old ZRT or Diagnostics labs that we alternative guys have been using forever. So when you want to save a patient some money and use Quest or LabCorp, I have a worksheet I can give you if you don't have it already. And you simply convert the units to put them all in the same units, and then you graph it out, and you can see what's normal on Quest and LabCorp, which means everything is normal. And you can see what's not normal on the ZRT and Diagnostics, and that is considerably more useful. So I'm really glad I did that little worksheet. Every now and then my OCD works out for me. Now you can do multiple specimens. It's called a timed salivary cortisol. I like to get 4: morning, noon, dinner time, and last thing at bedtime. So which of these saliva cortisol tests are the most reproducible? Here's a free download. Reproducibility is the highest between visits with an 11 o'clock or bedtime salivary cortisol and with that multiple specimen curve that I was talking about. Those are the best. Next highest is if you do something called the cortisol awakening response, which has been studied a lot, but doesn't seem that useful. So I'm not going to waste your time talking about it. And the very weakest of these tests is just doing a single 8 o'clock in the morning salivary cortisol. Damn. So our colleagues in endocrinology say the gold standard test is the synthetic ACTH stimulation test, or synacthin or cosentropin test. And the standard practice is to get them in the morning and shoot them up with 250 micrograms of synthetic ACTH, either IM or intravenously, right after you've drawn blood for a basal cortisol. And this dose is actually 10 times of normal physiological amount of ACTH. Okay, so it's a big, big whip of the adrenal gland. And then you test the serum cortisol again at 30 and 60 minutes. And they say normal is a peak cortisol that's, above 18 or 20. Now, 20 is just at the upper end of normal at most labs. So if your ACTH will float into the upper end of normal, they say there can be no problem, okay? But this is a very insensitive test. It's highly specific. If this test is abnormal, your gland is dead as a doornail. But it misses a lot of people with adrenal problems. So they tried to improve it with this little dinky low dose test. It's more sensitive, but it's still a blunt tool in their hands. Now, what about these people with secondary and tertiary failure? The gland hasn't been stimulated by ACTH. It's kind of atrophic. So what they do is they give ACTH again and again and again, and they measure blood cortisol again and again and again. And there's the description of it in Krusos's Endotext article. I've never had to do one and don't intend to. So what do I think is wrong with these studies? In clinical practice, so often the only test that's offered a patient is the ACTH stimulation test. So a number of my patients come to me and they've got a so-called normal test. And I want to just make an analogy. Imagine if we tried to test the thyroid gland this way. You got a patient with a free T4 that's a little low, 0.52. ARUP says 0.55 is normal, right? So we injected 10 times of a physiologic dose of thyroid stimulating hormone. Somebody's got their, Barb, I think your speaker's unmuted. And so after you've given them a big blast of TSH, if the T4 gets up to about 1.19, then the patient's absolutely got no problem. No, come on, man. That's a wink and a nudge right there. That's a Pollyanna idea. What is the ACTH stimulation test missing? Well, one of the things that's missing is adrenal fatigue or reduced reserve. So what do I mean by that? Well, here's my picture of what I think a reduced adrenal reserve is. The ACTH stimulation test will force the adrenal to squeeze out as much cortisol as they can. But what if a maximum response is a normal amount, but there's nothing left in the adrenal afterwards? I mean, here's 2 of my tubes of toothpaste on my bathroom counter. Pressure gave the same amount roughly of toothpaste on each brush, but you can see there's a big difference between these 2 tubes, even though the test result looks pretty similar. So does that mean the tubes are just the same? I don't think so. Does adrenal fatigue really exist, as Hans Selye claimed in 1936? So a lot of us say, yeah, Selye was correct. But the authors of a recent meta-analysis say, oh, no, he was wrong. They examined 58 studies of salivary cortisol. Those were the only tests these patients had. And meeting their inclusion criteria, 29 studies of the awakening cortisol response, 27 studies of a general awakening response, and 26 studies of the 4-test cortisol rhythm. And these guys said there is no substantiation that adrenal fatigue is an actual medical condition. Therefore, it is still a myth. And I put this in here because this is the car keys dilemma. If you have looked 3 places for your car keys and you can't find them, is it fair to say car keys don't exist? I mean, you might have tossed them in the refrigerator when you unloaded the groceries. I've actually done that once. So in my opinion, the adrenal fatigue is a valid issue. And I think this analysis, if anything else, proves that saliva tests alone are not sufficient to prove the problem. You need to do more tests. And I agree with the authors of this paper who stated a single biomarker may not be sufficient. It's just insufficient. So let's look at some more evidence, please. In the first place, even the endotext authors will validate the concept of adrenal reserve. Remember, the slide said that secretion in response to stress may be suboptimal by the time you get way down here. And any major or even a minor stressor can precipitate an acute adrenal crisis. So if you have stress and a crappy adrenal, you can't make enough cortisol, so what are you going to respond to the stress with? Right, it's like Barney Fife. You freak out, you get all Mr. Adrenaline, like Barney, because that's all you got to respond to the stress, and you don't have enough cortisol to tell it to sit down and take its place. So Hans Selye's exhausted adrenals and his dogs are giving all they could in order to meet their daily needs. They had nothing left. And is there any other validation than this flight of logic? Well, Jonathan Wright reported way back in 94, observing patients who had had a so-called normal ACTH stimulation test complained that a few hours later, their symptoms just got terrible and they felt awful for the rest of the test day and often the next day too. And Wright had the opinion that after the adrenals ooched out enough cortisol to make a normal 1-hour post-ACTH level, they had nothing left. And he called it the stumbling runner phenomenon. I was on the track team, and when a runner is running as fast as he possibly can and you push him from behind, he's usually going to lose his balance and fall forward. He can't go any faster. And if you interfere, you're going to make him break his stride. A similar response to this was reported after testing patients with an anxiety disorder, and the psychiatrist who did the study called it a lowered recuperation capacity. In other words, you just ain't got nothing left. So are there tests that are more sensitive? Well, Jonathan suggested a 24-hour ACTH stimulation test, which is what we used to do in the 70s when I was just getting out of medical school. We didn't have a sensitive enough blood test, so we'd make the patient do a 24-hour urine collection, actually 3 days in a row to get enough cortisol back in the day, and then you gave them an ACTH injection and you collected another 24-hour urine. Or when I was in med school, 3 ACTH injections, one each day for 3 days. That's in my old Harrison's Book of Medicine. Anyway, if you do this, a 24-hour urine collection, you give them an ACTH at the start of the second day, do another 24-hour urine collection, you expect their cortisol output normally to double. And if you send it to Meridian or to do a Dutch to get the metabolomics, the precursors, the waste products, you're going to see some stuff go wrong. Simply doing a 24-hour urine adrenal steroid profile can be handy, and that's offered by Meridian and Reen and some in Asheville, North Carolina, and now the Dutch test too, the purveyors of which claim is reasonably equivalent. So, you know, a Canadian dollar is reasonably equivalent to an American dollar, I guess. Try to spend one of the Canadian ones around. So, what other advantages do we see in just the plain adrenal steroid profile? Well, in 1937, the idea of looking at precursors and metabolites was introduced, and it is still a valid and viable approach, now called the field of metabolomics. The metabolites are looked at. So it's defined as the study of precursors and byproducts. And as I mentioned in slide 28, in adrenal insufficiency, cortisol is the last hormone to become low. So if we do only a 24-hour urine cortisol, we're going to be the last to get the news. If you do the entire steroid profile, you see the metabolomics and you see the precursors and the breakdown products, and you get greatly increased sensitivity for things that are going wrong. And the Germans like it. I think the Germans are pretty OCD type physicians. So there's the worksheet I made years ago on Christmas vacation at my mother's. I took all the books I could find. This is cholesterol, and these are the steps. Cholesterol is turned to pregnenolone, which is turned to progesterone, and eventually to DHEA. Progesterone is turned to corticosterone, to aldosterone, or to cortisol. And flipping to the sex hormone pathway, you get testosterone and estradiol, and DHT. Okay. And I used to just graph my results out here when I was really needing to see it. And so I'll give you guys a speedy tour through this because you've seen it before. ACTH regulates the conversion of cholesterol to pregnenolone, and it has lots of other fine-tuning steps so that the amount of ACTH, the effect of ACTH can be up or down regulated, just like the fine-tuning knob on my microscope in med school. Pregnenolone goes to progesterone, and we have a real hormone right now. This production is enhanced as needed, and the enzyme here, 3-beta-hydroxysteroid dehydrogenase, is inhibited by feedback from its downstream products, particularly DHEA, estrone, androstenedione, and testosterone. So progesterone does double duty. It's a trophic hormone. And in an expansive moment, Dr. Searle said, oh, it does 200 different things. Probably not, but you get the idea. And it's a precursor for other more potent hormones. So here's how we move from pregnenolone and progesterone across to the sex hormone pathway. And the sex hormone pathway is controlled by luteinizing hormone. This enzyme 1720-desmolase is a big player here. And this is one of the ones that's blocked by chronic stress. So the luteinizing hormone pathway starts to be produced at age 6 or 7. That's called adrenarche. That's when our kid's bedroom starts to smell a little mousy. They're making some smelly little steroid hormones. And these are the two life or death steroids, cortisol and aldosterone, without which we die. And the sex hormones are made over here, and they're optional. So when you're stressed, luteinizing hormone goes away. And I showed you guys that when cortisol is produced, that's the active hormone. And what's fascinating is the body deactivates it. It's like when you cash your paycheck, most of it you put into the savings, into the bank. So you get money when you cash your paycheck and you put most of the money into the bank. So cortisol is deactivated to cortisone once it's made, and you have a pretty robust amount of cortisone that is rapidly flipped back to cortisol, unless you're taking licorice, in which case you can't convert cortisol to cortisone. So I don't use licorice for people with adrenal insufficiency. It's just stupid. It's like cutting up their debit card and making them carry the cash in their pocket and pretending they've got enough. They don't, okay? But it is nice because if we need cortisol in a hurry, if we happen to be hit by that bus, we can convert cortisone to cortisol in one super quick step and have it right when you need it instead of moving through all of those conversion steps I showed you before. So there's the effect of stress. It increases ACTH, increases cortisol, may increase aldosterone, and it blocks LH so you don't get much sex hormones. And all of these precursors here get to go to cortisol. So the use of metabolomics will show, in the first place, the waste products. That's the stuff that you've just broken down your hormones. You don't need them, so let's get rid of them. That's the first to show low or high adrenal production. Then the precursors will often show you that luteinizing hormone has been reduced or there's a loss of reserve. The hormones, aldosterone, cortisol, the last to become abnormal. A lot of studies have been done looking at the cortisol-cortisone ratio as a measure for adrenal reserve. I don't try to calculate it. I just kind of look at the relative positions of each one and go, okay. And then I mentioned the 5-alpha to 5-beta reductase ratio when we discussed insulin resistance with PCOS and PMDD patients. So here are a couple of cases. And you guys have seen these before in the earlier lecture. This is a woman with insulin resistance who is overdriving the production of cortisol because high levels of insulin go to the hypothalamus, tell it to make excessive amounts of corticotropin-releasing hormone. So you have excessive ACTH overdriving the adrenal, plus insulin itself increases the amount of adrenal production. This works on a lot of levels. This woman had a normal amount of cortisol in the upper half of normal, but to keep it normal, she was getting the hell rid of a lot of it. She had high breakdown of the allotetrahydrocortisol and pretty damn robust tetrahydrocortisol. And by the way, this is the 5-alpha reductase showing the insulin resistance. More andro than etiocalanolone. This is 5-alpha. This is 5-beta. More allo. That's a 5-alpha than 5-beta. So elevated waste products. Look at that. Tetrahydrocortisone is high. High waste products and 5-alpha, 5-beta imbalance for this woman with insulin resistance. This is the professional athlete who had burned himself out, came to me wondering if he needs testosterone because his testosterone blood level was pretty crappy and his free testosterone was pretty crappy. And if you look at his cortisol, the single most important hormone on the page, yes, it's normal. But look, there's so little cortisol, he's just not breaking down a normal amount of cortisol or cortisone. Even his allo is in the low half of normal. And the sex hormone pathway, DHEA is low, androstenedione is low, etiocalanolone is low. No wonder his testosterone is low. His adrenals shot, and he's having a hard time making enough. And I believe from later work on the case, it was hypothalamic dysfunction. This was a 55-year-old woman who came to me with chronic fatigue and a history the previous, maybe 2 years before, had ended endometrial cancer. So her test didn't look all that bad. She was somewhat obese and she had more 5-alpha than 5-beta, more 5-alpha than 5-beta. So it looked like insulin resistance, but her cortisol, cortisone, pretty well balanced. Breakdown products, not bad. Precursor here, not bad. But then she came back to me freaking out because she had been diagnosed with recurrent uterine cancer. And so now we're looking at what stress does to the adrenal steroid profile. And the stress had blocked her sex hormone pathways. And she was using more cortisol. She needed more to handle the stress. So the cortisol, one of the breakdown products is low, and her corticosterone breakdown products are low, and everything on the luteinizing hormone side of this profile is now low. So let's look at the pretty good, not much stress, and the stress. And I think you can see where the red lines show up. That's where the effects of stress are hitting her. Now, a friend of mine sent me this, and he was worried about it. He said, "Oh my God, this patient has got asthma, and I did her adrenal steroid profile. Big Al, everything is low. Oh my God, what's happening? What's happening? She's taking a steroid." And I said, "Yeah, man, she is taking a steroid, and that 5 milligrams a day prednisone she's taken by mouth was enough to completely suppress her own adrenal function. But it didn't suppress her aldosterone. So this is a typical adrenal steroid profile of a secondary adrenal insufficiency. And in this case, she was suppressed by the steroids she was taking for her asthma. And I have seen a few of these by people only using steroids inhalers for their asthma. Just a steroid inhaler can give you exactly this amount of suppression. And this is a person who probably needs a medical alert bracelet, honestly. So here are a couple of useful studies for steroid synthesis problems in the top caliber athletes, mostly professional tennis players. Those tennis pros, man, they're big money. And people who are chronically stressed, and even in animals subjected to various stressors. The gonadal or steroid sex hormones are downregulated with stress, as I said, so their precursors can make cortisol instead of wasting your time reproducing and rather stay alive. The sex hormones are also made by the adrenals, and I kind of test them as proxies, so I don't have to do many adrenal steroid profiles anymore. I did a lot of them in the 90s. I haven't done one for a few years now. And men and menopausal women more than 55, or you just test them when you test them. Women who are cycling, I like to test them on day 4 just for consistency. Even a perimenopausal woman, her cycles may be pretty irregular, going from 28 to 40 or 60 days. But if you get them on day 4, you're exactly where you are. Okay. So what do you do to treat these people? Well, again, after I've tested for what I suspect, let's fix what we find. So after the first visit, I give virtually all my patients information on the core issues of adrenal fatigue and insulin resistance, because most of my people have both of those. And so you got to start with the adrenals. That's the first. The cortisol is essential for every metabolic function. And as I said, the adrenal gland is the furnace of the metabolism. And then the thyroid is next, and the gonads and neurosteroids depend on the foundation of healthy adrenals. So I start by supporting the adrenals, and I do not like to give people hydrocortisone. I just do not. And I'm going to tell you how to do it, because every now and then you have to. I had an 80-year-old man who fell and smashed his leg, and he was dying in a nursing home when his family called me. And by God, he was in Addison's. So you start out with a hydrocortisone, not prednisone, not any synthetic steroid, but hydrocortisone is preferred by internists and endocrinologists for Addison. So for once, they're using a bioidentical. Good for them. It doesn't last that long. You have to give about 20 to 30 milligrams a day in 3 divided doses. And I'll talk to you later if you want to ask me about a bedtime dose, which nobody talks about, but I've seen it, and it works. So you give the largest dose on waking to mimic normal levels, except it doesn't, because it takes a few hours to get up to normal. So the patient wakes up, takes his pills, and then feels like crap in the morning, okay? A.J. Clear, brilliant Brit, did a number of studies and validated the benefits of low-dose hydrocortisone, 5 to 10 milligrams a day, to treat patients with chronic fatigue syndrome and hypothalamic pituitary axis dysfunction. You guys have read William McKee Jeffries' book, Safe Uses of Hydrocortisone. and Clear proved that Jeffries was right. But Clear later cautioned against using it because if you have a hypothalamic dysfunction, it just suppresses it more. The body just can't make that much, and it also further depresses the sex hormone production. So he's saying it gives you a short fix, but a year later, you wished you hadn't done it. And I kind of agree with that. So if you don't want to give the patient a completely suppressive replacement dose of 20 to 25 to 30 milligrams a day, what are your alternatives? Well, the first I mentioned, organotherapy. Give cytosine AD. It's a glandular. It has no hormones in it, but it does supply the nutrition your body needs to convert cholesterol to steroids. And that happens in the brain, in the adrenals, in the gonads, in the mitochondria, and even the skin, and probably other places too. And the best of them is the cytosine AD, and the second best is Dr. Wilson's Adrenal Rebuilder. And for vegetarians, it's Metagenics Cortico B5, B6, which is, okay. The tissue has just the tiniest amount of cortisol, less than 500 milligrams per 100 pounds. So that's an awful lot of tablets. But many brands do contain nanogram doses of cortisol and even added T3. Mayo Clinic felt very smart in proving this. They looked at 10 different brands and they said they're all crap, man. So I wish the people didn't add stuff, but I have a funny feeling the added T3 may have come from a thyroid glandular element because the FDA doesn't regulate T3 in desiccated thyroid glandular supplements. They only regulate T4. Okay. And remember, the timing of these gonadal doses is glandular doses is really important. Like when a patient is taking hydrocortisone for Addison's, you take it when the body really needs cortisol. First thing in the morning, a big dose, a smaller dose at noon, a little wee dose in the afternoon, gets them by. But when you give nutrition for the synthesis of the hormones, you have to give it when the body is actually making cortisol, and that occurs overnight. So if you look at the normal diurnal rhythm of serum cortisol, it peaks in the morning when you wake up and it bottoms out at bedtime. So that's when you take a dose of cytosine AD, and 2 or 3 hours later, when it is in the circulation, that's when your body really needs to use it. You crank out the hormones. And again, with this nutrition, you can definitely find refeeding symptoms. The patient's wide awake. They wake up at 3 in the morning and they do more chores before the alarm goes off at 7 than they ever accomplish during a normal day. They have enormous energy. And remembering dreams vividly seems to be a hallmark of recovery from adrenal fatigue. My adrenal patients generally just simply cannot remember their dreams. And when you put them on the stuff, they start remembering and it can freak them out. So I start my patients with a small dose in the morning, 1 tablet or less, because if I'm going to make them hyper, I'd rather have them hyper at 9, 10, or 11 in the morning than 1, 2, or 3 at night. And I generally gradually build the dose as tolerated to take 2 in the morning, 1 at noon, and lastly, 1 and then 2 at bedtime. And I've got a little instruction sheet for you guys if you don't have it already. So here's a guy, and I think I've shown this man before too. He was 42 when he came to see me. He's 67 now. He had a uvulopalato-pharyngoplasty for sleep apnea, which fixed him. He was allergic, taking immunotherapy, and he was on desiccated thyroid, USP for his goiter. And he had mild residual symptoms. This was way back in the day when I didn't routinely give people adrenal. So he was one of my first adrenal workups. And his AM-ACTH was incredibly high, 338. Remember, 60 by the endotext people say is diagnostic of Addison's disease. His cortisol, though, was 16.1. So by flogging the hell out of his adrenals, he was able to ooch out enough to be normal. His 24-hour urine ACTH stimulation test was abnormal. On the first day, he didn't look that bad, but on the second day after the ACTH, he crashed. He had low cortisol and low cortisone. I tested him for the Addison's antibody, negative, in 1992-ish. That wasn't a big surprise. And I didn't even really understand the glandular, so I gave him DHEA. He took 25 in the morning, 25 at bedtime, and his ACTH dropped to 59, but it was still higher than the reference interval. So that's when I added the cytosine AD, and his ACTH dropped to 29. And he remained normal as long as he took the adrenal cortex. He stopped it for a while in the late teens of the century. I came back into town. I mean, in the early teens, I tested him. I got him back on cytosine AD, and bingo, he's great again. So besides the adrenal glandular, what else can we do? Well, the DHEA gives us a clue. I like to start women with pregnenolone. Pregnenolone is the first product of cholesterol, is mediated by ACTH, and we've seen that chronic stress can block production of ACTH. And so when the ACTH is too low, you don't get enough pregnenolone. And when you give your patient pregnenolone, it will replenish the supply that has been diminished by the stress-related ACTH deficiency. And pregnenolone supplementation has been repeatedly shown to increase progesterone production in research and clinical use. And progesterone, as you know, has many benefits. Progesterone reduces pain, reduces the stress response. It has a mild GABAergic effect on the brain as a neurosteroid, and it will slow down to replenish other steroids, cortisol, aldosterone, and the sex hormones. Pregnenolone is really safe. The downstream enzyme regulation I mentioned earlier prevents overproduction of cortisol due to any excess of its precursor. And there is this feedback inhibition. The 3-beta HSD is inhibited by DHEA, estrone, androstenedione, and testosterone. So bingo, protection from excessive use of it. So I like to start the pregnenolone after my patient is already doing the adrenal glandular. I start my women with 10 milligrams at bedtime. A lot of them need 20 milligrams a day. Some like taking it all at once at bedtime. Some like divide it, half at bedtime, half in the morning. And a few women, it wakes them up so much at night that they like to take it in the morning, at least until they're used to it. But usually the bedtime dose really helps women sleep. And insomnia is a big problem for women in their 40s, particularly. A lot of my cycling women will simply double whatever they normally take during the day on days 14 through 24 when their ovaries are trying to make a whole lot more progesterone, and that gives them nice regulation of their cycles and makes them happy. Men, you got to limit their dose of pregnenolone to 5 milligrams a day. It's best taken at bedtime. And that's because of the side effects I'm coming to. What are the side effects of pregnenolone? Well, the real side effects are because it works. It replenishes the downstream products. So people get a lot more cortisol than they're used to. So they'll have too much energy. And the bedtime dose will wake them up. They've got more cortisol at 4 than they used to have at 8 in the morning. Okay. And then aldosterone is made so people are able to retain their salt and their fluids, and their shoes get tight and their rings get tight, and they gain about 4 pounds of water weight until you downregulate the renin. Remember I said the plasma renin goes high when aldosterone goes low? Well, it takes a few weeks to get rid of the renin and the vasopressin and whatnot that's made to compensate for crappy aldosterone. So they will get better by the end of the month, but they may need some re-encouragement when they step on the scales and freak out that they're 4 pounds heavier and they came to you for weight loss. Progesterone is the next thing you get to keep after cortisol and aldosterone. And so women will get about a half a cup size breast enlargement and nipple sensitivity, and that goes away in about a month or less. And then with all steroid replenishment, women's cycles may resume as patient 1 did, or they may simply become a lot more regular. And this is where you have to warn them that their fertility is increased. Even before you give them thyroid, give them adrenal nutrition is ovarian nutrition, and that means they're more fertile. And accidents cause people. Okay. Now, in the case of patient one, she was absolutely thrilled and had the cutest kid I've seen in a while. But, sometimes it's not a pleasant surprise. The neurosteroid effect of pregnenolone is sometimes good, sometimes not. It'll calm them, even make them drowsy, but it can even make them really fatigued. And so you may have to lower the dose until they get over the fatigue. And then again, in men, I gave about 10 men 10 milligrams of pregnenolone, and about 6 or 7 of them got breast enlargement. And so you keep their dose down to 5 milligrams a day. They feel calm and relaxed and pleased, and they don't grow tatas. Now, the second precursor I mentioned earlier, that's DHEA. It's cheap, easy, over the counter. There are a few bad brands, and this has been proven to be useful in patients with chronic fatigue syndrome and chronic inflammation. DHEA also significantly reduces the development of diabetes from metabolic syndrome. Weird, okay? And when you supplement DHEA, you bypass the second step that's blocked by chronic stress, which is inhibition of luteinizing hormone. Luteinizing hormone controls the 1720 desmolase or lyase that converts 17 beta pregnenolone to DHEA. And so when you drop DHEA in, it's like airlifting supplies to your surrounded 101st Airborne in Bastogne in 1944. You give them what they need to go down and make sex hormones. And as evidence, we have seen that studies have shown that DHEA supplements will yield twice as much testosterone as will equally dosed precursors that are on this side of the 1720 desmolase. So the 1720 is blocked, the DHEA avoids the block, and you get double the amount of product from it. And it's really safe because downstream enzymes are regulated, and giving DHEA cannot force excessive production of testosterone. What DHEA does is it can restore testosterone and androgen effects to patients, even those with Addison's disease. And most of the studies have been done for women with Addison's, and it's positive. Prospective studies have shown DHEA will improve testosterone and benefit men with hypogonadism, soldiers who are going through survival training who are incredibly stressed. One of my good friends had to drop out of Ranger training. It was a nightmare. And patients with chronic fatigue syndrome as well. Now, what happens if you give more DHEA than you need? Well, any excess is usually cleared out as DHEA sulfate, as sulfur conjugated in the liver. And I want you guys to notice, I just repeat with these references to prove it, that giving too much DHEA cannot and will not force men to make too much testosterone. Ain't going to happen. But here's the issue that if you have a lot of DHEA floating around in the bloodstream, it can be locally converted by your skin. Your skin can make all the steroid hormones and it'll convert it to testosterone and DHT in the skin. So patients will get facial hair and excessive acne on the face and back, especially, God forbid, women with PCOS who already have too many androgens. Now, as a weak androgen, if you give too much DHEA, well, damn it, it will block the androgen receptor. So it will downregulate the androgen effect of a person's testosterone. Or it can go to estrone, and where it may enlarge a man's prostate. The usual woman's dose of DHEA would be 0 to 10 milligrams a day. I've had a few women who needed, 15 milligrams. I've given them more, they didn't need it. I had to feel my way on this in the early 90s. And the usual man's dose is 25 milligrams a day. And I would encourage you not to give more than 50 milligrams a day, starting with 25 milligrams at bedtime. And I just want you to know, as we kind of saw with my patient 2, a precursor like DHEA without a glandular is not fully effective. And when I gave a number of men what I gave patient 2, DHEA without a glandular, they got bad results. They went away discouraged and pissed. And so always, always, always give the glandular first. Okay, guys. Now, when you're treating hydrocortisone, you take it in the morning, at noon, and 4 p.m. And since the precursors and glandulars are raw material, supplying the stuff that's needed to make the hormones, you mostly dose them at bedtime when you're making most of the hormones, or you give some in the morning to maintain production during the first half of the day, and then none after noon until bedtime. If you give the stuff at the very beginning, I tried giving the adrenal glandular at dinner time, and I found that I couldn't sleep. I was my own guinea pig on a lot of this stuff because my body wanted to make cortisol and it didn't have the required nutrition. So when it got the required nutrition at the wrong time, it made cortisol at the wrong time and I couldn't sleep. So remember what I'm telling you here. And generally speaking, I don't really have many patients who need to take more than 40 milligrams a day of combined pregnenolone and DHEA. That's about what it takes. And remember, the body will not make more than it wants. So when you give more than that amount, the body doesn't want to make the hormones and it just causes mischief in their skin. Okay. Now, when you have a patient taking oral DHEA, they actually do make an intravaginal DHEA called prasterone. But oral DHEA, it has to go through the liver, and the liver conjugates a lot of it to DHEAS. So any patient taking oral DHEA, if you look at a urine steroid profile or measure DHEAS in the blood, it's going to look high, and you're going to freak out, think, oh my God, I'm giving them too much. So you monitor DHEA therapy by testing unconjugated DHEA, okay? Or testosterone, or you can do a urine adrenal steroid profile, but remember, they pass out the excess in the urine. So I just do an unconjugated DHEA in the blood test to monitor therapy and a testosterone. So here's an alternative to doing all of this stuff. Naltrexone. Who knew? When I was treating men with clomiphene to get their testosterone up, it occurred to me, damn, I wonder if naltrexone, which is a POMC receptor blocker, would do the same thing in the hypothalamus that the clomiphene, which is an estrogen receptor blocker, does. And I went in the literature and there's a bunch of articles on it. Absolutely. The action of naltrexone is its expected action to block the opioid receptor on the HPA axis. So the HPA axis said, oh shit, and it just squeezes out more CRH. There are multiple studies that show 25 and 50 milligram doses of oral naltrexone increase both ACTH and serum cortisol. And they say naltrexone is a safe drug at 25 and 50 milligram doses. Now, you guys know that we use low dose naltrexone. We start with 1.5 milligrams for most people, and down at Nova, Nancy Klimas and Irva Ray start with 0.1 milligram in the morning for a PTSD vet in their VA down there, because these guys' adrenals are shot, and you just have to block them a little bit to make a big difference. So what about low dose naltrexone? It's been shown to help chronic fatigue syndrome, fibromyalgia, and the complex regional pain syndrome. And it's said to downregulate the inflammatory response of the immune system. But I'm telling you, I think it does more. It does more than reduce pro-inflammatory cytokines. It does more than protect the microglia. It actually increases ACTH and it increases cortisol. And this is a great thing to use on those 10% of people with chronic stress that causes hypothalamic dysfunction. Now, one of my patients, I couldn't get well for anything. And I started the 1.5, 3, 4.5 milligrams of low dose naltrexone. Didn't make a damn bit of difference. And I moved her up to 9 to 18 to 27. And at 25 milligrams, her cortisol and ACTH came way up. And then after about 6 months, they were high. So we had to back the dose down. So sometimes low dose doesn't do it. And you can get into the bigger doses, which the Brits have printed in paper are safe.